It was just about a week and a half ago that the International Society of Thrombosis and Hemostasis, along with the American Heart Association, put out a statement on advancing research in VTE. And some of the measures and discussions that they were having when trying to map out, essentially, as leading institutions, tangible measures to improve the fields of care, really focused on variations of clinical research, what we need to do to apply to human trials, what those human trials need to look like, and how do they advance care, what do those markers look like, things of that nature. And Dr. Zarek, with it being a topic that we get into oftentimes but not too frequently, can you give us a little bit of background on your perspective, I guess, as to how current VTE research stands? What are the big players, and what have we been looking to accomplish in recent years?
With further ado, thank you for calling me. I really appreciate the opportunity. I think this is a topic that's been almost like a big bear sitting in the middle of a living room. We all are very much aware of the mortality and morbidity related, and we've known about it for a couple of decades now, at least. Just to remind you, 2008, I believe it was a Surgeon General call for action, and it was sort of notable somewhere in the news and in the media that we should be raising the awareness for the VTE. The numbers at that point stood about the same as they stay today. Unfortunately, about 1 million people annually in the United States have suffered a VTE every year. And of those, 700,000+ have a DVT, rest is a PE. PE may be either embolic or in situ. And the problem is, frankly, that all of those PE and DVTs are highly, highly complicated with morbidities that follow in over 50% of the cases. The grim prognosis of folks who have a DVT with post-lymphatic syndrome in 50% of the cases, and 5 to 10% of those may end up with really advanced stages of venous hypertension and even ulcer. So these are quite comorbid conditions that may affect the lifestyle and really are extremely costly for society. I don't think we moved iota since 2008 in terms of dropping those numbers down to any substantial or measurable level. And the research has been done. A number of research studies have been printed and published, and you can't say that has not been any effort to do so. The paper that AHA and the International Society of Thrombosis and Hemostasis came about was really collected over a number of a year and a half, and really generated mostly in 2018. And the writing group was about to publish it and was published just recently, but last minute the COVID-19 was added or piggybacked to the pathology because we found it to be pertinent. The research covered is a translatory research that would start essentially from changing anything from the bench to patient care to the public. So at all 4 or 5 stages that they listed, they suggested numerous ideas where the changes and enhancements start and be focused on. I think what we need to start with is the Berghoff's triad of actually how the clotting or accelerated thrombosis starts. We really have not improved understanding of that triangle of the venous stasis, abnormalities in the venous or vascular wall, and molecular crosstalk between the structures that may actually trigger and lead you from the hemostasis, which helps you stop the bleeding, to a accelerating thrombosis, which causes clotting and closes the lumen off, up to understanding the modalities in terms of the treating mechanically, removing the clot, treating the clot with thrombolysis, or simply applying the conservative measures. There's a whole host of ideas that the society has brought up to the upfront. Obviously, the newer NOAC or new anticoagulation, the factor 10As and direct thrombin inhibitors have been around for a little over a decade, I believe, and pretty much took over the VTE arena. Some of the issues are that we really have not studied some special cases, such as folks who have high body mass index. Those subgroups have not been studied for appropriate level of anticoagulation. There's been an explosion of iliac vein stenting, which you might have heard, and I'm sure operators and physicians who are dealing with venous disease and cath lab have come across a number of patients, especially from OPLs of various kinds, who ended up with iliac vein stents. And it's not quite clear what the protocols would be for, if any, anticoagulation in those subsets of patients. So there's a number of niches when it comes to the newer anticoagulations, which are not studied in a randomized proper trial yet.
Wow. Wow, that's honestly very fascinating from the front of where exactly we need to go with these agents and methods of care. Exactly, the patient subpopulations kind of come as a surprise to myself personally. Assuming, of course, upfront with it being so, linked to, cardiovascular risk, that these certain groups would be accounted for this further into it. But as you mentioned, not one iota of improvements.
Yeah, it really hasn't. The overall numbers really have not moved to any measurable, substantial level. So I think the call for action this time would be and should be really aggressive and should really involve the research at every stage, from the bench studies and ideas to obviously in animal models, and then transitioning that to healthy volunteers that can study the methods of both diagnosis, which is lagging, the newer ultrasound techniques that involve the high resolution of clot and assessment of the vein wall to predict the chances of VTE recurrence is something on the forefront. And I think the engineering in biotech is on the verge of coming up with phenomenal software and programs on ultrasound machines which can be incorporated to look into those. We've been relying too long for casual assessment of the venous ultrasound, looking into hypoechoic image, venovascular dilatation, level of compressibility, and guessing whether the clot may be recent, basing that also on the clinical history that a patient gives, versus a very hyperechoic, scarred, and contracted looking vessel, which is likely to be more chronic. But the newer, ultrasound techniques are there on the horizon, and I think they're very promising. We all understand that treating any type of VTE, whether that's a lower extremity, pelvic, or PE, but in lower extremities, particularly where ultrasound has a huge role for diagnosis, and treating them early, preferably within 24 to 48 hours, translates directly into a chances of recurrence and complete clot resolution. So it matters tremendously that it's done properly and that the diagnosis is given early on.